This is TTT Live. I'm DK Rostar. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, and on Facebook at TTT Live Online. We go now to the Manager of Corporate Communications at the Ministry of Health, Candice Alcantara.
Good morning, and thank you for joining us. It's Al Alexander this morning. The Ministry of Health's virtual media conference, we welcome you for this video conference, the 26th of May 2021. As you know, at these media conferences, we provide an opportunity for members of the public to hear directly from the subject matter experts and medical practitioners on the front line of this fight. The Ministry of Health remains committed to providing you with relevant, accurate, and up-to-date information on the national COVID-19 response. Our panelists today are Dr. Miriam Abdul-Richards, Principal Medical Officer, Ministry of Health, Dr. Avery Hines, Technical Director, Epidemiology Division, Ministry of Health, and Mr. Roshan Singh, Geographic Information Systems Manager, Epidemiology Division, Ministry of Health. For this morning, I am your moderator for this morning's program. We begin with Dr. Abdul-Richards, who will present today's clinical and hospital occupancy updates. Dr. Richards.
Thank you very much, Mr. Alexander. Good morning to my colleagues, Dr. Hines and Mr. Roshan Singh from the Ministry of Health. Good morning to all members of the media. Thank you so much for your continued attendance at these press conferences. Good morning to the listening and viewing population of Trinidad and Tobago. This morning, I would like to present to you the most recent media release from the Ministry of Health and the clinical statistics, as well as a brief summary of the hospital occupancy figures in our parallel healthcare system. I'll start this morning with the clinical update, number 735 for the Trinidad, as per the media release that was released at 4 p.m. yesterday. As of 4 p.m. yesterday, 612 new positive cases of COVID-19 were confirmed, which brings the total number of active total positive cases to 8,444. The total number of positive cases since March 12, 2020 to present is currently at 20,879. Thus far, unfortunately, we have had 408 deaths. Yesterday, we had a total of 10 additional COVID-related deaths, and we would like to extend condolences to the family members of the deceased. There were 30 persons discharged from public health facilities, and I'll go into a bit more detail in terms of the hospital occupancy figures as of 7:30 a.m. this morning. I'd just like to provide a brief summary of the hospital occupancy figures within the parallel healthcare system, and I have a very short presentation which depicts those figures. In total, over the last 24 hours, we added 93 beds to the parallel healthcare system, an additional site, which is the Tagarigua step-down facility, which is equipped with oxygen and for transitionary care for persons who require such care, has been activated in Tagarigua. The full capacity of that site is 38 persons. The day-based step-down facility was increased to an occupancy of full capacity of 90 beds, and that's a 40-bed increase as of yesterday, and the Point Fortin New Hospital was increased by 15 ward-level beds. The total capacity at that institution is now 75. This brings the total number of beds available in the parallel healthcare system to 891. I'd like to reiterate to members of the population that the bed status is dynamic. It is based on a supply-demand equation, and we continue to try to increase the number and level of beds in line with the demand for beds. As of this morning, the total occupancy in terms of the parallel healthcare system is at 66%. Could someone just please post the slides so that we can have the viewing population follow? And in Trinidad and Tobago, there is the overall occupancy in the parallel healthcare system decreased marginally to 71%. That decrease is due to the addition of 93 additional beds. The figures in Tobago are 32% continue to hold. Of course, when we look at the disaggregated figures, we see a 60% occupancy in the ICU figures. When we disaggregate ward level figures, the total ward occupancy is at 67%. This is a decrease of 73% from yesterday, again, due to the addition of these 93 ward level beds. In Trinidad and Tobago, the ward occupancy decreased from 82% to 72%, and in Tobago, it continues to be on or around 32%. Now, with regards to the ICU and HDU levels, we do transition ward level beds at the Couva Medical and Multi-Training Facility, Arima General Hospital, and at the Augustus Long Hospital, as well as now at the Point Fortin Hospital, from ward level beds to ICU level beds to HDU level beds, based on the level of care that is required. It's important to note that the clinical course of patients with COVID-19 continues to be one in which patients are very ill and require any time between 5 and 12 days at our hospitals. As such, we have noticed a variable occupancy level in terms of our ICU capacity. This morning we are at 80% overall, with an 86% occupancy in Trinidad and Tobago, which was an increase from 58% yesterday. Again, we've noticed a fluctuation in terms of the trend for high dependency unit beds, and at present we are at 48% nationally, which is reflective of the Trinidad and Tobago figure as well. At present, we have 15 hospitals or institutions within the parallel healthcare system for care of ill confirmed COVID positive patients. At this time in Trinidad and Tobago, where we have 13 facilities, approximately 12 of those facilities are above the red zone, which is 75%. And what we've noticed is, in spite of us increasing beds, they continue to be filled. We are looking at a net increase in beds of about 31 cases per day across the system. Again, I would like to remind the population that in order for someone and a patient to receive optimal care for COVID-19, all resources need to be coordinated and available for a bed. That is nursing staff, personal protective equipment, and medical personnel. Again, I would like to appeal to members of the population to please continue practicing the 3 W's. Let's continue to be a resilient, responsible, and civic-minded population as we continue to wash our hands, watch our distance, and let's wear our mask properly. Please, ladies and gentlemen, this is the only way that we can close that gap, and we are hopeful that if you practice these measures daily and continue to be your brother's keepers, we will overcome this war with COVID-19. Thank you ever so much for your continued attention this morning at our conference.
And thank you, Dr. Richards, for that update. I now hand you over to Dr. Hines, who will present the latest epidemiological report. Dr. Hines.
Okay, thank you, Mr. Alexander. Good morning to my colleague. Thank you. Apologies. Thank you, Mr. Alexander. Good morning to my colleague, Dr. Richards, and to my colleague, Mr. Singh. Good morning to members of the media and members of the viewing and listening public. I'm aware that we did have some technical issues with the slides. I'm not sure if they're now available. If they are, I'd like to go to the first as we update our population on the current situation with the statistics in our epidemic. The slides available, yes or no? Here we are. Thank you. We can go past the first to the second slide. So we've done this. Let's move to the second. And we see with that second slide that we are looking at those cumulative cases where we see that total cumulative positive coming up to 20,879. On the next slide, if it becomes available, you will see that we began a new uptick, a new surge later on. In the March into April period, it has continued on a fairly steep trajectory thus far, and we do see where the time it took to double the total number of cases has again begun to shorten. So this doubling point or doubling time that we were keeping track of here had slowed until we were taking nearly 6 months to double between September and April. But then we took only 41 days to double between April and the 10th, or rather the 16th of May. We are taking note of that, as that speed is one of the things that we measure in the assessment of whether our epidemic is speeding up or slowing down. So we can see that it has sped up, and we are hoping that as the implementation of various restrictions takes effect, that we will see some slowing in that trajectory. Next slide. The slowing that we are hoping to see, we do believe that the numbers of new cases over the past few weeks has actually begun not to decrease, but not to increase as quickly. And that trajectory that we had initially put as the green line, that upward slope that said we'd be going up very quickly in the period between start of May and now, we have seen where, while we did continue to increase, we didn't increase as quickly as that, with the interpretation that some of the measures that we did put in place were in fact beginning to bear fruit. Next slide. We look at our epidemic curve, and we see, beginning on the left, those gray bars that represent the July 2020 to the end of December 2020 period. We see that there was a peak at the August-September time frame, and that peak then dropped off from the middle of September going down towards the end of December. We know that peak was as a result of the movements, etc., that would have been happening in early July into August, and that when we began to implement additional restrictions and additional regulations, including, most importantly, the mask wearing, we did see the decrease of those cases eventually begin to manifest itself in the figures. And as we move to the right, we see the colorful bars, the different colors representing the different months of 2021, the gold ones being the ones for May, and we see that we saw a steep increase starting from maybe the second week in March and moving upwards, and that the highest numbers that we saw so far have been those around the 11th, 12th, 13th, 14th of May. And we are now beginning, hopefully, to see slightly smaller numbers attributed to swabbing on each day. But again, we keep an eye on the data to see whether any retrospective data changes those figures. Next slide, please. Looking at this, which is a little easier to interpret, if not easier to see, the week-by-week changes that we have been seeing in total, in the total confirmed cases at the end of a week. We do see that increase began around epidemiologic week 10. Epi week 10 corresponding to the week that began on the 7th of March. And whereas we saw initially small percentage increases, those percentage increases did eventually become larger. We saw around Epi week 14, 15, 16 that we started to see larger increases from one week to the next. And the percentages that aren't as easily visible there began to go up from 50 to 70 to 80% increase from one week to the next in that time frame. We are now seeing that while we do continue to accumulate increasing number of cases from one week to the next, that percentage of increase is in fact a little smaller, has become smaller consecutively over the last 3 weeks. And we're hoping that this, again, corresponding to the fall away of those cumulative cases. We're hoping that this change in percentage is representative of the braking force that we are applying via all the public health regulations and recommendations that we have implemented over the past several weeks. If we move to the next slide, we see the same information but on a monthly time scale, and the time scale showing the number of cases for May takes us up to 10,000 plus cases just for the month of May, as opposed to the just over 2,000 plus for the month of April. So we do see, well, just over 2,700 rather for the month of April. So that, coupled with the background information on the positivity, that is the number of tests done that return positive out of every 100 being around 45%, that indicates to us the kind of the situation with regard to levels of circulation of the virus and what may be driving additional cases as people continue to interact with one another. Next slide, please. We do have the same demographic distribution, and whether you look at it over the entire time scale of community spread, which is what we see here, or whether you look at it over shorter time scales, we still see that about 55% approximately of the cases diagnosed have been in the 25 to 49-year-old age group, and that slightly over one half of the cases have been among men. When we move to the next slide, the deaths, however, did change in profile to some extent. And when I say change in profile, what we're seeing is a slightly higher proportion of deaths in the under 60 age group than we were seeing previously, and also a slightly higher proportion of deaths among the women than we were seeing previously, so that whereas initially or in the early phases we were seeing 75% of the deaths being among men, that has dropped to 61% among men, and the 25% among women has risen to 38%. So we do take note of that change in the demographic. And if we do have the next slide available, what we see is that geographic distribution of cases going through all of the various community centers, so to speak, at this point, the places where we have lots of population, and that distribution currently reflects that the virus and confirmation of the virus is currently taking place across the community, across the population. We will see a little more of that with the geographic information slides if those manage to come in. I know we had a little technical glitch, but that distribution just reminds us that there is no place in the country where we can say, well, we don't have COVID here, so we can relax. There is, at this point, the need for the entire population to be on board with all of the public health measures to reduce the risk of transmission, to be on board with the maintenance of the mask wearing, the hand washing, the reduction of your movement, the maintenance of optimal distancing, so that we can continue to apply that braking force, continue to apply the slowing that we are beginning to see. We continue to apply that braking force, and the cases should begin or should continue to come down. But we really are at a very delicate point in this transition where we need to do all that we can, as well as we can, in order to get the effects that we want in the shortest possible time. So I believe I'll wrap it up there and turn you back over to Mr. Alexander.
Thank you very much, Dr. Hines. We welcome back Mr. Roshan Singh to provide the latest GIS report. Mr. Singh?
Yes. Thank you very much. Dr. Richards, Dr. Hines, Mr. Alexander, members of the media, and members of the listening and viewing audience this morning. I say a special good morning to you all. As we move into my second slide, which will be my first map this morning, we begin by taking a look at the mapped laboratory confirmed cases during epidemiological weeks 17 and 18, with epidemiological week 17 representing the period the 25th of April to the 1st of May, and epidemiological week 18 representing the period the 5th of May to the 8th of May. And generally what we see from the points on the map is the same pattern which we have been seeing for some time, and that is a high number of cases along our population centers and along road networks we note, of course, the high number of cases mapped to that east-west corridor region, starting from as far as Diego Martin in the west and heading all the way down to Arima in the east. Of course, we see what is taking place in central and Chaguanas and surrounding areas, and as well as San Fernando and surrounding areas. Now, as we switch to our second slide, we take a look at the map representing the period epidemiological weeks 18 and 19. We'll see that as we switch to the next slide. Correct. What we see again is a similar pattern along the east-west corridor, along the road networks, and mainly in our population centers. This is where we continue to record a high number of cases. I'll point out, however, at this point that data for epidemiological week 19 is currently being mapped and is still being processed. And as such, by the time we have finished mapping that particular epidemiological week, it is quite possible and is anticipated that the gold bars on the chart, which we see to the left of the map, those bars will be higher, taller than the purple bars, which would show that we would have recorded and mapped more cases in epidemiological week 19 when compared to 18. So that will show us the continuing growing trend and increasing numbers as the weeks go by. As we switch to our next map, we take a look at the same data as Dr. Hines would have shared previously. However, this data, the same data, is aggregated at the community level. And this particular map represents epidemiological weeks 18 and 19 combined. So that is the period 5th of May to the 15th of May. And as he correctly pointed out, there is nowhere that is really safe in the country when we think about it, because most communities are affected across all counties in Trinidad and Tobago. We'll point out that the highest range in this map is over 50. So that speaks to the amount of cases we are recording in single communities, far less when we look at it at a county level, at a national level. I will point out as well that the community which we see to the top left-hand side of the map, which would be the western part of the island, that particular community is one which we will give special consideration to, because in that particular community, persons were mapped to a particular facility and not their home, so we will take that into consideration in our interpretation of the data. Now again, using the same data for epidemiological weeks 18 and 19, covering the period the 2nd of May to the 15th of May, we take a look at our next map, which will be showing the same data aggregated at a different output area level. And we see here the spread of cases continue again across the main areas of high population centers and along the main road networks in the country. We see the highest density of cases, as depicted here on this particular map, is really noted within the Port of Spain to San Juan area, with, of course, pockets across the entire country. Now, one of the questions that people would often ask and would think about is my community safe? Is my area safe? And I think it's important for us to not look at it from that particular perspective. We cannot only think about the community that we live in and wonder if it is safe, because we also need to consider those around us. We also need to consider there is still movement taking place in the country. So it's not necessarily accurate to say my community has less cases, so we are safe, or my community has more cases, so we are less safe. We all need to continue to follow the measures. We need to continue to wash our hands, wear our masks, and watch our distances. And equally important is the fact that we need to restrict movement as much as possible and avoid congregations and gatherings. That is important because, as I mentioned, it's not just about what is taking place in your community, it's about what is taking place across the entire country. We are a small country. It's easy to traverse from one point to another, and we therefore need to be cautious as we continue to do our part. Taking a slightly different look at the data now, we switch to our next slide. Looking here at epidemiological week 17, again covering the period the 25th of April to the 1st of May. And this map, of course, shows us again that the highest density of cases which we recorded was in that Port of Spain to San Juan area, with there being high densities recorded from areas from as far as Diego Martin to Arima, and several pockets across the country, such as Central in Chaguanas and San Fernando in the south, as well as smaller pockets in the Sangre Grande, Rio Claro, and Point Fortin areas. Again, as we look at the next map, which shows a similar representation of data collected during epidemiological week 18, we see a very similar pattern again. And as we look to epidemiological week 19, which, as I mentioned earlier, is currently being mapped, which we will see in our next slide, again, a very similar pattern arises. So we continue to see where the high density areas are. They are the same. But of course, we cannot just look at the density. We look at it in relation to the point maps, which we showed earlier, as well as the choropleth maps, be it the community-level choropleth map or the regular hexagon output map, which we shared when interpreting the data. As the pockets are similar, we continue to see the same pockets and the highest density of cases in Port of Spain and San Juan. We must realize and we must appreciate that despite these areas being the areas which represent the highest density of cases, there continue to be cases in other parts of the country. It simply means that the cases are not as dense, so they are not as close together. But it doesn't mean that the cases do not exist in areas of lower density. As we switch to our next slide, we take a look at a comparison of the a comparison of the cases mapped by county for the period epidemiological week 17 to 19, again from the 25th of April to the 15th of May. And we note, of course, that increase in cases in epidemiological week 18 when compared to 17. And as mentioned earlier, we are currently mapping epidemiological week 19, and it is expected that by the time we have finished mapping epidemiological week 19, we would have mapped more cases in that particular epi week compared to epi week 18. I will point out, however, that despite the fact that we are still mapping data from epidemiological week 19, both St. George West and Victoria show that we would have already mapped more cases there in epidemiological week 19 when compared to 18. So it shows that upward trend in these counties, and of course that is something which we need to take into consideration as we really re-emphasize the point that we need to continue to practice the measures. And of course, as I move to my final slide of the presentation, I remind us all that to access credible information from the Ministry of Health, you can go to the Ministry's website at health.gov.tt/COVID-19. And of course, we have the GIS-based dashboard, which we can access through the drop-down menu on that particular page. Before I close again, I want to re-emphasize the point that we need to wash our hands, wear our masks, and of course, watch our distances, as well as we need to restrict movement as much as it is possible and avoid congregation and gathering. As I close, I want to say a special thanks to the GIS team and the data processing team at the Epidemiology Division, who have been doing an excellent job. So I think it's important for us to recognize those efforts as well. So thank you all very much. I'll hand back over to Mr. Alexander.
And we certainly thank you, Mr. Singh, for the update. We now move into our question and answer segment. Media representatives, please begin by stating your name and your media house before you put forward your questions to our panelists. Our presenters will respond to 2 questions per media representative in the first instance. And of course, if time permits, we will accommodate an additional question for each media house. We begin with 98.1 FM.
And a very good morning to you again, Mr. Alexander. Stephen Cummings, 98.1 FM. Just quickly, question for Dr. Hines and the other for Dr. Abdul Richards. I first start with Dr. Hines. Dr. Hines, I'm not sure if this question rests with you in terms of a response, but I'll pose it anyway. Now, sign language interpreters of the deaf have expressed to me some concerns over what they believe has been a lack of urgency on the part of the ministry in treating them as among frontliners for vaccination. Now, interpreters also claim that they continue to face risks since they cannot be maskless during interpreting. And even being masked itself, presents a sort of unique challenge for them because, they have to use full facial recognition as they communicate with the deaf community. What further guidance or policy is there for sign language interpreters as a response? And Dr. Richards, I continue to be baffled, over these high numbers of infections, even during a prolonged period of lockdown, public health restrictions, and indeed a curfew. Compared to a previous period, we were reporting smaller numbers of infections, and now we appear to have tripled and even doubled on a percentage basis when we look at, let's say, hospital occupancy alone. My concern and question is, what could really be responsible for these high numbers, and especially when I believe we have more of a sort of a conformative population, even though being forced by law to adhere to all, to all that is required under health, safety, and security regulations. Thank you.
Thank you, Mr. Cummings. Dr. Hines will address the two questions.
Okay, thank you for your questions. With respect to the query and the concern raised by the interpreters, that's been taken on board. We will reach out and try to figure out what the best approach is for ensuring that the needs are satisfied. So we will work on that behind the scenes. With respect to the second question, I am in turn baffled by the continued questions on why are we still having these high numbers. If we are in the midst of a surge that is being recognized as the biggest that we've had in the population to date, we don't expect that suddenly the numbers will disappear quickly. The braking force that is applied by all of the measures, by all of the restrictions that have been incrementally, bit by bit, stronger and stronger, implemented over the past few weeks, that braking force isn't a sudden cut-off. It is going to take some time for the speeding epidemic to slow down and then to turn around. So in a situation where we're seeing levels of positivity among our tests being in the 40s for the past several weeks, meaning out of every 100 tests that we do, we get 40 of them or more that are actually COVID positive, reflective of high levels of circulation of the virus in the population. That reflects the fact that we do have widespread infection that is being driven by person-to-person contact, by person-to-person interaction, and the slowing effect that following the recommendations would have is tempered by the smaller segments of the population that may not be following them. So the extent to which we are 100% adherent is the extent to which we have 100% of the braking force applied. Any leaks, so to speak, in that braking force by movement when we shouldn't have movement, by people not understanding the importance of the masking, any of that then reduces the effectiveness of that braking force, and we continue to see those numbers. What we are seeing, as we explained, as we highlighted, over the past few weeks is that although the numbers have been increasing, they haven't been increasing as quickly. And we're hoping that this is signaling the beginning of success with those braking measures. But that means that we need to try harder to maintain the braking pressure until such time as we get the desired effect. So I'm not sure that there is another reason or another explanation beyond this is the way communicable disease epidemics work, and the response to the epidemic, or response by the epidemic to the implementation of measures, is something that takes some time. So we're seeing that we've been applying the brakes, and we're starting to see slowing, and we need to continue to measure the change against our behaviors. As we want to see more change, we need to be more strict and more stringent in how much we adhere to the measures that are in place to protect us. So I'm hoping that explains.
Thank you for the admonition, Dr. Hines. We now go to the Newsday.
Hi, good day. This is Paula Lindo from the Newsday.
Hi, good day.
So I have a couple questions. The first is whether the public education campaign being employed by the ministry and the state is working in light of the communications experts who have been saying otherwise. And does the health ministry or any other ministry have any data on the rates of rejection of vaccines by people who have been offered them so far? Thank you.
Thank you very much. Dr. Hines, would you?
Okay. Now, the only metric that we would have for whether the communication approach is working is the extent to which people are following, understanding, accepting the guidance that is being provided. And we are seeing increasing levels of understanding. We're seeing conversations where people are talking to others in their circles about what has been said in these conferences and in other domains. And the conversations are trending in the direction of getting a wider understanding of the need for adherence, the need for acceptance of the vaccines. And just moving directly into the vaccine question, what we're seeing is a lot of vaccine demand. We are seeing very vigorous demand for vaccines. People wanting to get the vaccine, people are clamoring for appointments. We have not seen any significant levels of people not accepting vaccine when offered. So we are quite heartened, and we want to continue to encourage the population to continue to demonstrate that level of vaccine interest, acceptance, and in fact excitement that has been demonstrated so far.
Thank you, Dr. Hines. We now go to I-95.5.
Good morning to everyone. Midfield Turner from I-95.5. Just a suggestion for Dr. Singh, if possible. If we can put the Tobago data on a separate slide from the Trinidad data to make it easier for persons to see and to absorb. Dr. Hines, I believe I can ask you my two questions this morning. The WHO was recently cited in a report saying that the death toll globally from COVID-19 could be up to 2 to 3 times higher than what is being reported. In light of that, is there a need for us to take another look at how we attribute deaths to COVID in Trinidad and Tobago? And secondly, as it pertains to data on children and teenagers, if you can just talk a little bit more about that. Are there any warning signs that parents would like to look for, as well as any update on the figures as it pertains to persons with long COVID, COVID tools, MIS-C, and those sort of things? Thanks.
Thank you.
Okay, thank you. The question you raised with regard to the death toll is something that has been discussed in scientific circles in terms of whether there are deaths that are being missed, for want of a better word, globally by the death registration systems. We have several backstops in place, including swabbing of persons who may have passed under circumstances that weren't automatically directly related to respiratory illness, so that we do monitor deaths, especially more sudden ones or those that occur quickly in the community. We do monitor to see if we're missing anything there. We're also looking at the overall data, which does take a bit of cleaning and work to see whether we are experiencing what they call excess mortality, and we are updating the figures on that at this point in time. We will be able to make a comment in short order, but up to the last set of data that we had coming down to the end of last year, we had not been experiencing any excesses in the overall rates of mortality for the population. As we get the remainder of the data for this year, we'll be able to make a reassessment of whether that situation still obtains or whether it has changed. So that will be information that we bring to you as soon as that sort of analysis is completed. With respect to children and teens, the best metric, I suppose, that we have at our disposal, at least today, is the shape of that pyramid that we've been looking at since the start of the epidemic. And we're seeing that there is that narrowing, that constriction down at the bottom of the pyramid, representing a relative level of protection for children and teens compared to their overall proportion in the population of nearly 30%. We see that the representation of children and teens among the COVID-19 positives is somewhere around 10%. So we do know that what we're doing is to some extent working in terms of protecting them. if we want to look at the updates on occurrence of things like Miss C, COVID-2s, etc., that would better be addressed in detail by the pediatric clinicians, and we can always request that one of those individuals come back on to share updated information at the earliest possible convenience. So hopefully that takes care of the 2 questions asked.
Certainly, Dr. Hines, and thank you very much. IETV, we are ready for you. IETV, we're ready for your questions. Okay, we're not hearing the audio, so we will go to AZ. Okay, we're ready for your questions.
Okay, great. Vienna Hayes, IETV News. My 2 questions. Can we have an update on the Brazilian variant? How many cases do we have up to today or this week? As well as, I'm not sure if I missed it, but an update on the occupancy rate of the 2 field hospitals. And if I'm allowed this question, Mr. Singh would have noted a very dark spot on the top left in one of the maps, and he said it was mapped to a facility, not to the person's home. Can we have some clarity on that, please? Thank you.
Okay, thank you. So with respect to the Brazilian variant, I think we need to acknowledge something important. The numbers that we have reported in terms of the random sampling of cases and detection of the variant will not represent all the cases of the variant that have occurred in the population. At this point, where a new variant has been introduced into a population, the old and new variants establish something of an equilibrium where some generalized proportion of the cases will be the new and another proportion will be the old. At the current time, with the limitations that we have in the ability to sequence widely, we are still attempting to get a clear picture of exactly what proportion that would be. But we do know that we would have more than the individual numbers that we identify when we do sequencing. So counting the numbers that way is probably not the most useful metric at this point in time, but we do want to make it clear that once a new variant is in circulation, there will be some proportion of those cases that we see on a day-to-day basis that will be new variant and a proportion that will be old variant. And maybe that proportion will settle somewhere in the 30 to 40, 20 to 30 range. At this point, we don't know. So we do have to continue our work in the background to do the sequencing. And when we have a clearer, better picture of that, we will be able to give you a more accurate idea, not of the numbers, but of the overall proportion that we think could be attributable to new versus old. The second question with respect to the hospital occupancy, I will turn over to Dr. Richards.
Okay, thank you very much for your question. Thank you very much for your question. As of 10 a.m. this morning, the Cuba Field Hospital is at an occupancy of 31%, and the Port of Spain Field Hospital is at an occupancy of 100%. It is imperative to note that during the day we continue to have admissions, discharges and transfers through these units, so the number will vary. However, the trend out of the Port of Spain Hospital, which was activated approximately 1 week ago, has been a 100% occupancy at all times. Thank you very much.
Thank you, Dr. Richards, and we remind the media that we will take 2 questions in the first instance, and if time permits, we will take additional questions. We now move to AZP News.
Good morning, Priya Bihari, azpnews.com. My first question is about the some months ago, I think the minister had mentioned about an online system that would be live in terms of the vaccination. I just wanted to find out that, and he said that they're now going to have some sort of trial system. Can you give us an update on that? But I've been also told that the IT system within the ministry may be experiencing some problems, and in some instances has crashed, and it has been difficult to gather information and disseminate information and gather data. Can someone shed some light on that? And my second question, maybe to Dr. Hines, the debate that is taking place now, whether the current upsurge was caused by the candlelight vigils or by the gathering in Tobago on Easter. I don't know if you want to shed some light and put an end to all of the discussions and when exactly do you think that this current surge would have started? What would have been the catalyst for this? Thank you very much.
Thank you very much, Prior, for your question regarding some operational concerns regarding the vaccination. The back-end IT systems are up and running, and yes, we do appreciate that some members of the population are experiencing challenges. However, I'd like to reiterate that vaccine appointments are being given within a 72-hour timeline from persons. The concern about the Ministry of Health's IT system, the IT system is again up and running. I'm not sure where you're speaking about in terms of statistics and figures, because we are receiving all our hospital occupancy figures, our epidemiological statistics from Dr. Hines and Mr. Singh. We would like to recognize and thank the population for their high rates of interest in the vaccine and their vaccine acceptance as we move forward to gaining herd immunity. Thank you very much.
Okay, and thank you for the second question. I'm not sure if we can pull back up that week-on-week graph that we would have had from my slide set. I think it was slide number, 3, 1, 2, 3, 4, slide number 4 or 5. So let's see if we can pull that up. In the meantime, what we note from our statistics, from our information, is that we began to see a week-on-week increase in the number of cases recorded from about the start of week 10. Week 10 corresponds. Nope, let's move forward. So next slide, next 2 slides. So while they fix one more. Yes, while they sort that, we have on the next slide. There we go, perfect. We have the numbers of cases reported by week, and then the percentage change. So what we were seeing around the weeks of the middle of February was that that's the middle of February, week 7. We had seen 34 cases. Week 8, 29, so it was going down. Week 9, it started to turn around, so it didn't go down by as much, 27. And then by week 10, it started to go up. So we had a 37% increase in week 10, and 89% increase in week 11. So week 10 is the 7th of March, week 11, 14th of March, week 12, the 21st of March, a 64% increase. So we began to see a steady increase from one week to the next, beginning as early as that second week in March. And then while that increase looked like it might have been slowing a little, week 12, that 64% went down to 58% increase in week 13, 35% in week 14. Week 14 corresponding to the 4th of April, we then began to see large increases. So from week 14 to 15, 72% increase. Week 15 to 16, 85% increase. So the movements that would have been taking place at both of those time periods, or just before both of those time periods, would contribute to additional mixing of a population that has circulating virus. And to the extent that there's any movement and mixing, there is the increased risk of transmission. We saw it in the July to August time period. Movement and mixing then precipitated a spike in the August into September time frame. We're seeing again, we had lots of things going on. We had the reopening of sporting activities against that backdrop. We had people who were going to church and not well. So the driving factors for the surge at that point in time are multifactorial. Increased movement, increased interaction for sports, increased movement because we were free to go to church and do other things that if we were ill would spark cases. And we did see the initial sets of cases in weeks 10, 11, 12, starting off in the central area of the country, and by week 14, which was week 14 is really that Easter weekend and beyond, we saw additional increases. But the increases preceded Easter and would have been in part related to whatever activities were happening before that, and then compounded by additional movement. So we had a surge on top of a surge. So the important lesson has not changed from 2020. Increased movement in a population with circulating virus is going to cause increased numbers of cases. And if you have one set of increases compounded on another in terms of movement, then you have one speed of increases compounded on another in terms of the spike, which is what we saw epidemiologically. Again, coming to the end of this, this graph, we are seeing now that week 17 was the biggest jump, where we had an 88% increase from week 16 to 17. Week 18, 38.5%. Week 19, 35%. Week 20, 27%. So we're hoping that now we're seeing that braking force manifesting itself in these smaller increases from one week to the next. But this is really only to encourage the population to continue doing what we're doing in terms of adhering to those public health regulations. Increase mixing, increase cases. Adhering to the public health regulations, decrease mixing, decrease cases. We need to keep on the we keep our foot on the brake with respect to that particular change that we want to see. I'm hoping that clarifies.
Thank you very much, Dr. Hines. We now go to TV6.
Hi, good morning. Alicia Boucher from TV6 here. My quick two questions. I remember at the start of this pandemic, the unfolding, persons were, they had to state quarantine. And given that the ministry has stated in the past, two of the areas where we have been seeing a high number of spread would be from, in terms of the corporate setting, as well as home quarantine. Given that now we do have the P1 variants in the population, we don't know to what extent. I was wondering, Dr. Hines, based on your expert advice, whether at this point we should be looking again at state quarantining more persons who are COVID positive to prevent at-home spread, especially in situations where, they live in a large household. So that's my first question. The second question has to do with the breakdown in comorbidities. Now, usually the ministry reports that, a person had comorbidities, passed away. So I'm just wondering, can you give us an idea of what those comorbidities are looking like, whether it's mainly diabetes, whether it's diabetes, hypertension, has that changed?
Thank you for the question.
Thank you for the two questions. Now, I think you'd appreciate that given the large numbers of individuals that we are currently designating as active in the population, the ability to home or state quarantine is really good to be reflective of what capacity we have for each. So the home quarantine will have to remain in force given the volumes of cases that we currently have designated as active. But we do have a lot of support mechanisms working in the background to hopefully reduce the risk of that quarantine, so to speak, being breached, people moving around when they shouldn't move around, etc., which we have had reports of having happened. Now, we have on several occasions at this press conference gone through the mechanisms that we would like to suggest and recommend for individuals to protect themselves in their households. Unfortunately, this never seems to translate itself into any other broadcast, so we'll repeat it again. One of the things that we do want to recommend, especially when people are at home and they know that they've been exposed, or if they're at home and they are actually ill, we want to recommend that no matter the size of the household, you designate yourself to a particular area of said household. You keep your mask on. You don't share spaces and you don't occupy the same space as the other members to the greatest extent that you can. You don't share utensils like cups and glasses. If there's a single bathroom, then we sequence the use of said bathroom so that all the people who are not ill use it, then they clean it down, then you as the one isolating individual use and clean down so that we can reduce that risk of cross-contamination from shared surfaces. In the places and in the instances where this is absolutely impossible, relaying that information and the situation to your county medical officer of health will then provide additional support in terms of whether on a case-by-case basis individuals can be considered for state quarantine to protect the other members of the family. It clearly can't be done for everyone, but a case-by-case assessment, where necessary, can be done. But the importance of those guidelines for reducing the risk of infection in the home, that importance cannot be overstated. That those guidelines do exist on the Ministry of Health website, and we would like to have the transmission of that information go beyond the press conference to other broadcasts where the information can be heard by a wider audience. Keep the mask on at home, keep yourself to one area of the house, keep the distancing, physical interaction to a minimum, even in the household. If this is impossible because of your situation, reach out to the CMOH, who can provide additional guidance and support. So those are the things that we really wanted to emphasize with regard to the household reduction of risk. Thank you.
And thank you very much, Dr. Hines. Time is coming down, so we'll quickly move to CL Communications.
Good morning, Nandaleen, Singh, Caribbean Lifestyle Communications. I was just wondering, we have received some information that a patient was placed in an isolation room at Mount Hope, but wasn't given food or water for about 3 days before being transferred to a COVID institution. I was just wondering, can you indicate why the COVID-19 patients are being treated this way, and whether or not you are in fact aware of this? And my second question is, I know we have gotten the 100,000 Sinopharm vaccines, but I was just wondering an estimated timing as to when we're going to be purchasing more from China. Thank you very much.
Dr. Hines, if you could shoot with the question.
Actually, that question I'd prefer to refer to Dr. Richards.
Thank you.
I'll refer to the first half of the question, which is regarding the care for COVID-positive patients at the Eric Williams Medical Sciences Complex. First of all, I can assure you that such an occurrence is highly unlikely, given that all patients with COVID-19 who are receiving medical treatment are managed and followed up by a specialist team, regardless of the institution. Also, even if a person or a patient is placed in an isolation room, it is done for infection prevention and control measures. That patient is regularly followed up by a team of physicians and nurses. And once again, that sort of occurrence is extremely unlikely. Thank you very much.
Now, I believe that the minister would have, in his previous announcements, spoken about the additional timing for additional batches and doses of vaccination. And I believe that the important thing to note at this point is that there are active negotiations, active conversations happening to ensure that additional vaccine is made available as quickly as possible. When any additional announcement on the potential timescale for more vaccine becomes available, then that announcement will be made either by the minister himself or by the chief medical officer.
And we will squeeze in one last question from the Express.
Good morning, Camille Hunt, Express. Dr. Hines, a question we've gotten is whether it's safe for persons who are born with a protein C deficiency and they're on blood thinners. Is it safe for them to take the COVID-19 vaccine, as well as persons who have a G6PD deficiency and they can't take certain medications? Is the vaccine recommended for them? And my second question is related to the deaths that have occurred. Do we have data on how many would have died in the ICU, the HDU, and outside of the hospital system?
Okay, so with respect to the particular conditions that you would have listed, we do want to advise every individual, especially if you know that you have an underlying medical condition, to speak with their treating physicians to look at the suitability of the vaccine for them on a case-by-case or one-by-one basis. So blanket statements are probably not the best ones to make with respect to any particular kind of deficiency, especially the ones that are enzyme-related, etc. So G6PD is something that's generally managed from pediatrics to go upwards. If you have a treating physician, you speak with them about the suitability of each vaccine for your particular individual case. Your second question actually reminded me that I missed a part of the question from Ms. Boucher, so I'm going to backtrack to that as well. Apologies. The background information on comorbidities, etc., has remained largely the same, with the diabetes and hypertension and chronic kidney disease being among the most common of the comorbidities. You have ischemic heart disease also in the background. Interestingly, the people with things like asthma, etc., are a smaller proportion of those comorbidities than we may initially have thought or expected. With respect to the ICU HDU breakdown, that is data that would have to be compiled in a particular way, and all of the data, the full data set, isn't fully available to me at this point in time. We are compiling it because we did note the question having been asked previously. As soon as that information is compiled and analyzed in the appropriate format, then that update will be presented.
And ladies and gentlemen, that's all the time we have for this morning's press conference. Thank you for joining us. We really do appreciate your presence at these conferences each week. We urge everyone to do their part to safeguard the health of our nation. For those facing COVID-19 fatigue, remember the 3 S's: self-care, support one another, and seek help. And please practice the 3 W's: wash your hands, watch your distance from others, and wear your mask. We close with the words of Dr. Leroy Calise, the Black Stallion. We can make it if we try, just a little harder. Be safe and goodbye for now.
This is TTT. Live for